السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. Uh, I would like first to welcome all of you to this presentation about hypothyroidism. I would like also to thank the organizing committee for inviting me to give this talk. I have nothing to disclose regarding this talk. So, thyroid in the history have many aspects. So people think that the thyroid enlargement or goiter is a sign of puberty, fertility, or beauty. Some people have thinking that it's only an organ to empty the space in the neck. So uh, over the so many years, we discovered that the thyroid has a function, and it's one of the most important endocrine uh, organ we have. So the hypothalamic pituitary thyroid axis, as you know, the hypothalamus uh, give the TRH, TRH stimulate the pituitary to give the TSH, and the TSH stimulate the thyroid itself to give the thyroid hormone T3 and T4, and that will give negative feedback on both hypothalamus and pituitary gland. To talk about hypothyroidism, you have to talk about iodine. It's come together. For a long time, the iodine is associated with hypothyroidism. So when we talk about the iodine transport, the iodine uptake by sodium iodine symbiote, then the bendrin take the iodine inside the from the cells to the colloid. Then the TBO will use the iodine to oxidize the iodine, and it link the iodine to thyroglobulin and make the coupling. And you know this physiology from before. So if any problem with any one of those cause hypothyroidism. So if there is deficiency in the iodine, there will be hypothyroidism caused by iodine deficiency and other disease. There is any problem with bendrin, there will be bendrin syndrome, which is also have deafness with the hypothyroidism and goiter. And when the antibodies affect the TBO, there will be Hashimoto thyroiditis. For years in the past, the iodine deficiency was the most common cause for hypothyroidism, and it's still in some of the countries like Congo and Himalayas. With the since 2019 or 2003, 2011, and now there is a decrease in the number of country with iodine insufficiency. In Saudi Arabia, for example, in 1995, there was some iodine deficiency in some of the area, especially in the southern Asir, in Faifa. There was a mountain, and the iodine deficiency was in that area. However, the last report from the WHO, they consider Saudi Arabia as iodine adequate country, and it's not anymore has any iodine deficiency. And this is of course because of the iodinization of the salt, the fast food, the way that we are cleaning the food and so on. The iodine is not always a good it's not always good for the thyroid, and there is a side effect from the iodine. And we will start by some physiological known effect of the iodine that causes hypothyroidism, and this is Wolff-Chaikoff effect, and this is affect actually the uptake of the iodine from the sodium iodine symbiote, and it lasts for 2 to 10 days, then it will escape. And if there is a failure in the adapter, the escape of this failure of escape of this effect, the patient will have hypothyroidism. So this is one of the side effects of the iodine affecting the thyroid tissue. The other effect is the plumber effect, which is last about 7 to 10 days, and it's affect the proteolysis of the that release the thyroid hormone from the follicles that's coming from the colloid, and that's have no escape, and it lasts for 7 to 10 days, but it causes hypothyroidism transiently. The adding to this, which is I think it's more important problem from the iodine, that the iodine excess actually cause thyroid immunity, increase the thyroid autoimmunity, and cause hypothyroidism and thyrotoxicosis in the patient who have, or in the countries that have iodine sufficient area. On the other hand, the iodine deficiency, as we talk, the goiter and nodules and goiter and hypothyroidism. But when we replace iodine, we did not do good in regard to autoimmune disease. And this is a study from Jazan, Saudi Arabia, in 2012, and it's clearly give a remark here that excess iodine intake may put population in a high risk of iodine-induced hyperthyroidism and other autoimmune thyroid disease. So replacement of the iodine caused people to have more autoimmune disease. One of them is the Hashimoto thyroiditis and hypothyroidism. And this is the iodine intake, and we show that this country is adequate, and one of them is Saudi Arabia. And this is the map of hypothyroidism, and you can see here Saudi Arabia had higher prevalence of hypothyroidism in this regard. Other countries also in Asia, Europe, North Africa, America, all had a problem with increased autoimmunity. So when we talk about hypothyroidism cause, is it so if we can categorize it according to the geography of the countries, so we said Hashimoto is common in the industrialized country, in iodine depleted area, and iodine deficiency is still in a number one cause for hypothyroidism in undeveloped area or in iodine depleted area. This is the etiology of hypothyroidism in general. So you have congenital hypothyroidism like aplasia or hypoplasia or in-error metabolism, inborn error of metabolism. And we have the autoimmune disease, which is the most common, either permanent like atrophic thyroiditis or Hashimoto thyroiditis, or transient like subacute thyroiditis or postpartum thyroiditis. And we have iatrogenic, which is related to the medication that we give to the patient, either anti-thyroid drug medication or the thyroidectomy or radioactive iodine deficiency. Iodine deficiency is still one of the causes of the hypothyroidism. Then we have secondary hypothyroidism, which is affecting the pituitary, which is either the disease or tumor or surgery or radiation, and tertiary, which is coming from the hypothalamus, if there is the hypothalamic disease, surgery, or radiation. Hashimoto by far is the most common cause of hypothyroidism, and it's autoimmune disease related to the antibodies affecting the thyroid. And you can see here in Saudi Arabia that we have two studies by chance, one done by Prof. Soleimani, he's the father of the endocrinology in Saudi Arabia, and one done by myself and my team. And one is done in 1995 and showed that 14% of population have positive antibodies. In our study in 2015, it was 25% of population. And in China, we have almost the similar effect. That's the 0.3 with iodine deficient have autoantibodies, and 1.3 with excess iodine. So this is almost telling us that Saudi Arabia, the iodine repletion was more. So this is Suleimani, Dr. Riyad Suleimani paper, and this is our paper, and show that the anti-TG antibodies is increased from 7.1 to 20%. And the anti-TBO, it's almost the same. So the autoimmunity in Saudi Arabia was related mainly to the anti-TG antibodies. And this is good that the population still have almost the similar percentage of anti-TBO. So excessive iodine intake promote thyroid autoimmunity and increase the positivity of thyroid antibodies, especially the TG antibodies. So this is from more recent data that's showing that TBO is more in specific than anti-TG. And in this table that I made here, that make differentiation between the anti-TBO and anti-thyroglobulin, and you can see here that the normal population still have 5 to 14, but more with anti-thyroglobulin, and in the Hashimoto thyroiditis 90 to 95, 30 to 50% anti-TG. So when we choose anti-TBO, when we choose thyroid antibodies that tell us about hypothyroidism or talk about the risk of hypothyroidism, it's anti-TBO and not anti-TG. Anti-TG is important in thyroid cancer patients. So anti-TBO, as I mentioned, it's used for diagnosis and assessment of the risk of hypothyroidism in special patient who's on special medication or Down syndrome or pregnancy or postpartum thyroiditis and so on. In the anti-TG, it is actually, if the TBO antibody is negative and the patient had positive anti-TG, it's rarely have thyroid dysfunction. So the anti-TBO is more specific antibodies in hypothyroidism. That remind me about the pathophysiology of the for the type 1 diabetes. And you can see here the anti-TBO is elevated first, then you have subclinical hypothyroidism, then you have overt hypothyroidism. Given that, we have to remember that it's multifactorial, genetic, environmental cause that can cause hypothyroidism or thyroiditis with all type, like Hashimoto, Baylis, or postpartum thyroiditis, and so on. Or also Graves' disease is also multifactorial disease. When you talk about the diagnosis of hypothyroidism, it depends on the symptoms. And you can see here, this is the study done by Dr. Ali Zahrani, which he's the father of the thyroid disease in Saudi Arabia. And he gave this, or he published this paper in 2020 talking about the thyroid diagnosis and symptoms. And you can see here there's many different symptoms of and signs of hypothyroidism, and you can divide it according to the system. It's affecting every system, every organ in the body, and you know all of this for sure. This is the phases of hypothyroidism, and this is the difference between patients who have hypothyroidism before and after treatment. And in this slide, I want to show that the most important symptoms that have the positive likelihood ratio or highest positive likelihood ratio of hypothyroidism is hoarse of voice, dry skin, and muscle cramps. You can see here in this study, they are showing here that the number of the symptoms with hypothyroidism is very important to make the diagnosis. And you can see in this, when we have differentiation between case with hypothyroidism and control. And if you have less number of symptoms, the control population have higher percentage of having 1 or 2 or 3. Once you have more number of symptoms, patients start to have differentiation, and you have the more likelihood ratio of diagnosis of hypothyroidism. Good that we have the TSH, and here this is our study that we did showing the TSH value in Saudi population, and you can see the the TSH is 2, and it's range between 0.95 to 4.37. And you can see here the difference. So you have lower TSH when you have negative antibodies. When you have positive antibodies, the TSH is always positive, is always higher than negative, either both or anti-TBO or anti-TG also. So a higher TG is associated with positive antibodies. Okay, so this is the histogram showing the TSH level, and this is showing the age and in Saudi subject. This is showing the gender, which is the female and male, and you can see here the diagram is the same, or the doom is the same. Also with ethnicity, it's the same. If you black, Mexican, white, non-Hispanic, all they have the same doom of the TSH result. And this is showing the same doom, and there will be in the other side you have subclinical hyperthyroidism. In the hypothyroid side, you'll have the hypothyroid or subclinical hypothyroidism. Okay, so subclinical hypothyroidism, I'm not going to talk about it in details here, but it's biochemical disease that it's common, and it's 60% of the patients will return to normal, and it depends on the antibodies and the level of the TSH and the presence of goiter. It's associated with higher mortality in some patients. However, with elderly, actually it is protective. So higher TSH is protective in patients more than 95. However, it's more in the increased mortality with higher TSH in younger people. The LDL will be higher in a patient with higher TSH, and this is the effect of medication in patients with subclinical hypothyroidism, and it decreases the LDL, and it have some effect on the cardiac outcome, and you can see also decrease the size of the gland, decrease the antibodies, but however the symptom is conflicting. In general, this is JAMA articles that collect the more accurate studies and more strong study, and it's all actually showed that treatment or no treatment have no major effect, and there is insufficient data to support the treatment of subclinical hypothyroidism. However, the recommendation is to treat the patient with higher TSH more than 10. If you have hemithyroidectomy, patient with goiter, high lipid, and nothing related to the weight of the patient. We always think that younger patient, less than 65 with TSH more than 10, or patients would have symptoms, you can't give a trial of T4. However, when you decide to give this medication to all elderly patients, you have to evaluate the pre-existing cardiovascular risk, comorbidity, and the TSH level, because it's better not to treat elderly patients. So this is the level of treatment to hypothyroidism: the euthyroid, mild subclinical, severe subclinical, overt hypothyroidism, and severe myxedema coma, and the treatment depend on the condition. Either you need sometimes to have IV thyroxine or oral thyroxine, and maybe trial of oral thyroxine. Maybe you need only follow-up and no treatment. This is showing the guidelines of treatment of hypothyroidism. However, when you decide to treat patients with hypothyroidism, 1.7 microgram per kg is the starting dose. In elderly, you give lower. Sometimes we start by 25 and increase it every 2 weeks, and so on. There is no allergy being reported from levothyroxine, and the higher T4 and lower TSH with the treatment may cause problem like osteoporosis and so on. This is a slide showing the effect on treatment, other treatment on the thyroxine, and I think this is well known to most of you. We published a paper in Ramadan, and we said that pre-iftar is better than post-iftar or pre-sahur thyroxine dose. The T3 combination, sometimes we consider this trial if we have proven hypothyroidism, if the symptom is persistent on T4, which is appropriately given, and the patient had good response to TSH, sometimes you give the trial. Give the trial for 3 to 6 months. If not working, you can stop. And this is, we're talking about the weekly T4. And sometimes you need it for patients who have poor compliance or very poor compliance, and this gives good result. However, the daily is better and more safer, especially for the cardiac outcome in the first 2 hours of the high dose. I will stop here. Thank you very much. And we'll happy to talk with you in the discussion. Thank you, Salim.